This lecture is specifically made for candidates who are appearing in Section 1, especially exams in which there are multiple choice questions in orthopedic surgery. This part is specifically for musculoskeletal oncological questions. During the exam, you have to remember some of the principles and some important facts to go through these questions. And most of the time, if you are able to deal with those facts, you are able to score 100%. Recalling the fact that generally the test aims to illustrate the lesions that are taught more frequently. So you don't need to try to overanalyze any question. Additionally, keep in mind that the question contains no distraction and that every piece of information is a story which is there for a purpose. It is the answer stem and not the query that contains the distractions. Utilize every bit of information provided in the question to your advantage. Often the question itself reveals the details that gives the answer. There is a purpose for every information given in the query. Before you go towards histopathological radiographs, read the question and imaging studies and try to come up with a basic differential diagnosis in your head. Next, choose the response that most closely matches the differential diagnosis you developed using the photos and your history. Usually, doing so, you will get through the right response. Don't forget to utilize the details in the query to assist you in getting there. Prior to any treatment, one must stage a lesion. That means there is no surgery and no biopsy and no invasive procedure before the diagnosis is clear-cut. Another thought process is, if you are treating physician, then make the patient comfortable, splint it, give pain relief, give medications, and transfer the care. The biopsy is done by the treating surgeon and is the final step in any staging workup in those questions. Another important factor is soft tissue lesions are mostly classified as indeterminate lesions on MRI, and a biopsy of the lesion is most always necessary to make the final diagnosis. And it is done after all the staging studies are finished. When a biopsy may not always be necessary to confirm the diagnosis of a certain determinate lesion like ganglion or lipomas, the majority of the soft tissue masses are mostly inconclusive. MSTS stages of a disease. A benign lesion are staged as below. 1. Benign inactive disease. Number 2, benign active disease. 3, benign aggressive disease. Benign inactive disease. 1, for example, latent cyst, burnout, fibrous dysplasias. 2, benign active disease like non-ossifying fibroma or enchondroma. 3, benign aggressive disease like giant cell tumor or aneurysmal bone cyst. Malignant lesion, as per MSTS classification, is divided into 2. A is intracompartmental, B is extracompartmental. 1 is a low-grade malignant lesion by histology, such as Chondrsarcoma, or 2, high-grade malignant lesion by histology, such as Osteosarcoma. And 3 is any grade lesion that has regional, that is nodal or distant metastasis. You have to remember that in case of osteosarcoma, the skip lesion, that is lesion in the same bone but separated from the primary tumor by normal marrow, makes it a stage 3 and not stage 2. American Joint Committee has a separate staging system. This is rarely and very rarely asked in exam. AGC system uses TNMG staging. T is for tumor, N is for spread to the lymph node, M is for the metastasis to distant organs, G is for the grade of the tumor. AGC system of bone. Remember, 8 centimeter is a critical size. AGC system of the bone. 1A, low grade, less than 8 centimeter in size. 1B, low grade, more than 8 centimeter in size. 2A, high grade, less than 8 centimeter in size. 2B, high grade, more than 8 centimeter in size. 3, skip lesion present. These are actually high grade. 4A, mets to the lungs only. 4B, mets with regional nodes involvement. AGC system of soft tissue. 5 centimeter is a critical size. 1, low grade lesion. 2, high grade lesion less than 5 centimeter or more than 5 centimeter and superficial. 3, high grade, more than 5 centimeter and deep. 4, any grade lesion with regional or distant mets. Describing or determining the prognosis of any lesion can be determined by the following order of importance. Most important, number 1, stage of the lesion. Number 2, presence of metastasis. Number 3, skip metastasis. Number 4, histological grade of the lesion. Number 5, size of the lesion. For soft tissue sarcoma, the prognosis is dependent on the following in order of precedence. 1, presence of mets. Number 2, histological grade of the tumor. Number 3, size of the lesion. Number 4, depth of the lesion. See the difference between the first and the second. In any lesion, it's stage of the lesion, but in soft tissue sarcomas, presence of mets changes the prognosis. But in generally, higher the grade of the lesion, the worse is the prognosis, or the most aggressive the lesion will behave. Another concept to remember is that higher histological grade tend to behave similar fashion as opposed to any specific soft tissue type. For example, bone, fat, nerve, any tumor arising, if the histology is high grade, they tend to behave similar fashion. A higher grade liposarcoma may behave similar way as high grade spindle cell sarcoma. Then it has to behave like low grade liposarcoma. Similarly, a high grade Chondrsarcoma will behave more like an osteosarcoma, and vice versa. Another exam question is, osteosarcoma generally present as stage 2B, that is high grade extracompartmental in young patients. Chondrosarcoma generally as stage 1A and in older patient. This is due to the slow progression of chondrosarcoma than the osteosarcomas. Another important fact is that high-grade bone tumor sarcomas are treated with chemo, surgery, and chemo sequence. Why chemo? Chemo reduces the risk of pulmonary mets and aids in improved overall survival. it's not a must to give chemotherapy before the surgical intervention, but it is a must to give chemotherapy after the surgical intervention to control the side effect of the disease. Now we go to soft tissue sarcomas. They are typically treated with radiation and surgery, plus minus chemo rarely if there is systemic or advanced disease. Never confuse a bone tumor treatment from soft tissue tumor. While radiation of soft tissue sarcoma significantly decreases the incidence of local recurrence, it has, by the way, no effect on overall survival of these patients. Also remember the fact that unknown lesion of the soft tissue and worrisome lesions of the bone should be biopsied after imaging workup is completed to confirm the diagnosis prior to undertake any treatment modalities. Now we start with the malignant lesion of the bone. Metastatic disease is by far the common of the malignant lesion seen. And this is the most common diagnosis in 40 plus years, lytic lesion with a destructive bone involvement. Remember the acronym LBP, lung, breast, prostate, and a rule 30-16-90 rule for plastic mets. What does it mean? 30% of the lung mets are plastic, while 90% of prostatic mets are plastic. Similarly, 60% of the breast tumors are plastic. Another important fact, osteoblastic mets are associated with tumor-secreted endothelin 1. So this can be an EMQ question. The most common lytic lesions are lung, renal, and thyroid. Usually the histopathology will show adenocarcinoma histology, glandular-like tissue in the fibrous stroma. X-ray shows multiple bone involvement, although an isolated met becomes an indeterminate lesion, which needs to be worked up. Mets tend to show up in the axial skeleton. Results, for example, in Bateson plexus, involving vertebral bodies, or in proximal humerus and femur. Lesion which is distal to the elbow or the knee as a mets is usually lung, rarely renal as well. So if you have an exam question with an X-ray showing metastatic lesion below the elbow with no skin involvement and destructive bone lesion, this can probably be either lung or renal. Of the osteophilic carcinomas, breast, lung, thyroid, renal, and prostate, about half of the cases end up with skeletal mets. Bone is the third most important site of metastasis after lung and liver. And thoracic spine is the most important location for metastasis. As an orthopedic surgeon, you have to maintain skeletal integrity and function. Pathological fractures or impending fractures, considering the risk areas like proximal femur, is the most common site of fracture, which need to be fixed with heavy metals, possibly with cement augmentation. Fixation is generally determined by the Meirer grading criteria. A fixation is suggested for score of 9 or greater, with a given 33% fracture risk, or a Harrington criteria. So remembering this fact, if the Meirer grade of the tumor is less than 9, still there is a risk of fracture, but the risk is low. But higher, more than 9, the fracture risk is 33%. Another important factor is avulsion of a lesser trochanter without any trauma is pathognomonic of mets in the proximal femur. Typically, the lesion, if around the hip, is treated with arthroplasty traditionally cementing long bone femoral components, or pain or impending fracture. Recent studies have shown that the standard length stems perform equal as the long stems in if the distal bone is clear from metastasis. Another newer data was suggesting that with Meyerl criteria, we are probably over-treating patients who would have performed well. Meyerl criteria can be asked in the exam. A score more than 8 suggests prophylactic fixation needed. This is for the exam purposes. A score more than 8 needs prophylactic fixation. Scores are 1, 2, 3, and then you can talk about site, size, pain, lesion. Site, upper limb, lower limb, peritrochanteric. Size, less than 1/3, 1/3 to 2/3, more than 2/3. Pain, mild, moderate, functional. Lesion, blastic, mixed, lytic. Another rarely tested Harrington criteria. 1. More than 50% destruction of the diphysial cortices. 2. More than 50 to 75 destruction of metaphysis. 3. Permeative destruction of subtrochanteric femoral region. 4. Persistent pain following irradiation. How to work up for metastasis? These include medical history, physical examination, routine laboratory analysis, plain radiograph of the involved bone and the chest, whole body bone scan, and CT of the chest, abdomen, and pelvis. These investigations gives a strategy success rate of 85% to have a clear primary diagnosis. Any very aggressive lesion that does not incite much bone response will be cold on bone scan. The metastases which are cold on bone scan are renal cell and thyroid. Also remember that the myeloma classically is cold on bone scan. So these are the cases which need skeletal survey and don't pick bone scan. Another important fact, metastatic lesion, prophylactic fixation done. Because his Meyerl score was high, this patient needs to be referred to radiology for irradiation. A 20 to 30 degree centigrade of radiation starting 2 to 3 weeks after surgery is recommended. And generally, it should be treated entire area of fixation. For example, if subtrochanteric fracture pathological has been fixed with a nail, all the nails should be radiated. Bisphosphonates is important to prevent further formation of lytic lesions. There are medications which are newer medication called N-containing compound, nitrogen-containing compound, and these bisphosphonates inhibit osteoclast activity by inhibiting protein prenylation and act via myelovalinate pathway. The old bisphosphonates used to be competitive inhibitor of ATP and induces apoptosis. Regarding the bone metastasis, lung mets has the overall worst survival. Usually it's less than 6 months and less than 5% for 5-year survival rate. Kidney is another worse prognosis if it has metastasis. So remember not to pick any fancy operative intervention in that case. Another important tested is Breast carcinoma gets secretion of PTH-related polypeptide, PTHRP, which induce osteoblasts to release rank L, which result in osteoclast activation and bone resorption. Osteoprotein blocks osteoclastic activity by inhibiting the rank. All lytic lesions are caused by tumor-induced activation of osteoclasts. Another for bone metastasis, renal cell mets develop large, aggressive, and destructive lesions that are very vascular and bleed. Embolize the lesion and operate within 24 hours. Isolated lesions are mostly treated with wide excision. Osteosarcoma, most common primary bone sarcoma. Classically, it's high grade 2B. Metaphyseal location, soft tissue mass, mineral density changes, usually blastic on an X-ray, but may be lytic, for example, telangiectatic osteosarcoma, or mixed with lytic and blastic lesion with destruction of the bone. Histology shows lacy osteoid around malignant small cells. Treatment with chemo, surgery, and more chemo. Remember that prior to the surgery, these patients needs evaluation for any chemotoxicity. For example, adriamycin can cause cardiotoxicity. Cisplatin, renal toxicity. Similarly, ifosfamide cause renal toxicity, and bleomycin, lung problems. But chemotherapy is the reason they survive their disease. Chemo induces programmed cell death and reduces the risk of pulmonary metastasis. Survival without chemo is about 17% only. As previously discussed, osteosarcoma comes at stage 2B, high grade, extracompartmental with no mets. But about 20% will come up with stage 3. Prognosis is bad for the later on. Skip lesions, if occur in the same bone, has poor prognosis, and they are counted as stage 3. 5-year survival continue to be around nearly 60 to 70%. A good chemo response is 90% necrosis of the cell, which suggests 80 to 85% survival. Limb salvage is the surgical treatment of choice, with wide surgical section followed by reconstruction. Don't forget to work up. Need to include the bone scan and chest CT for evaluation and MRI of the entire bone to look for skip lesions. Telangiectatic osteosarcoma is a 1 subtype with aggressive lytic lesion, which can look similar like ABC, but is more destructive. Patients who develop lung mets after the treatment have poor prognosis, less than 30% 5-year survival. Patient with familial retinoblastoma have increased incidence of osteosarcoma. The RB gene is a suppressive gene associated with osteosarcoma, and these patients have chromosomal 13 abnormality. Other risk factors include p53 mutation, that is Li-Fraumeni syndrome, Paget disease, and prior radiation. c-MYC and c-FOS are oncogenes overexpressed in osteosarcoma. Patients generally have elevated alkaline phosphatase because of bone destruction. Multiple drug-resistant tumors have P-glycoprotein pump that split out the chemo. This is present in 50% of metastatic lesions. Local recurrence typically portend a poor prognosis. Pathological fractures does not necessarily require amputation, given that overall survival appears unchanged in limb salvage cases, but this remains somewhat controversial. If asked in exam, always pick limb salvage and not amputation. Occasionally, osteosarcoma present as low grade, and as in case with low grade malignant lesion of the bone, treatment is wide surgical resection without adjuvant modalities. For example, parosteal osteosarcoma, which is arising at the distal aspect of femur, more common in females. Now, some specific type of tumors of a specific type of osteosarcoma, parosteal osteosarcoma, classically low grade, stuck on appearance to the bone, usually behind the knee. About 1/3 of the time, it invades into medullary cavity and seen on imaging. Histology show fibrous tissue with low-grade osteoid. This is rarely any soft tissue mass, but can be present. Treatment is wide surgical resection alone. There is no chemotherapy for a parosteal osteosarcoma. Prognosis is good, 80% 5-year survival. Far less than 20% chance of developing metastasis. Tumor comes back as dedifferentiated on final path. Prognosis is bad, and patient probably should go for chemo. Genetic marker identified is chromosome defined as ring chromosome 12q 13-15 translocation, a distinct finding in this tumor. Then another type is high-grade osteosarcoma. These are the real lesions, commonly happens in femur. 25% of these arises from the pre-existing condition like Paget disease, implant irradiation. Treatment is same as for osteosarcoma, that is chemo, surgery, and chemo. Survival is at best 50%. Now we go towards some of the facts of chondrosarcoma, second most common bone sarcoma. Malignant chondroid neoplasm may be primary or secondary. Primary arises de novo, and the secondary arises if there is a pre-existing chondral lesion, usually present in older age as low-grade lesion that is painful and slow-growing. The lesion may be central, peripheral, or extra juxtacortical. Look for lytic lesion or along with calcification on X-ray that show endosteal scalloping, erosion, and possible cortical breakthrough. Most lesion locations are distal femur, proximal humerus, and pelvis, particularly periacetabular region, but otherwise tumor can occur anywhere. Treatment is wide surgical resection. Chemo and radiotherapy has little effect on this lesion. Never pick a chemo or radiation for a chondrosarcoma. Low-grade lesion in the long bones can be treated with curettage. Adjuvant such as phenol or argon can be used in rare cases. This patient generally requires long-term follow-up given the slow nature of the disease. In generally, chondrosarcoma are graded by the histological grade, and there are grade 1, which is 90% survival, grade 2, which is 60% survival, grade 3, which is 30 to 50% survival, and dedifferentiated chondrosarcoma, that is 10% survival. A dedifferentiated chondrosarcoma acts like a high-grade sarcoma. This is histologically like a high-grade sarcoma juxtaposed to the more classic appearance as a cartilaginous tumor. They have very poor prognosis, less than 10% 5-year survival. A wide resection is still necessary. Chemo does not affect it. Dedifferential has the worst prognosis of all the bone sarcomas, second in line with the Paget disease sarcoma. So remember, dedifferentiated chondrosarcoma is almost similarly has a very poor prognosis, similar to a Paget disease osteosarcoma, the sarcoma which is developed in Paget disease patient. There appears to be a correlation between increased expression of telomerase RT and the development of local recurrence and metastatic lesions. question can arise how to differentiate a chondral benign lesion from chondral malignant lesion. So mostly these questions is asked in correlation with the chondrosarcoma differentiation from osteoblastoma, but can be asked in generally. Whether a benign chondroid lesion can be differentiated how from malignant lesion. So number one, larger the size, more chances it's a chondrosarcoma. Larger than 8 centimeter. 2, centrally located, that is axial skeleton involved as opposed to appendicular skeleton. Number 3, old age. Number 4, multiple lesions, for example, Musculoskeletal syndrome or Ollier disease. Number 5, hot on bone scan. Number 6, pain and local recurrence. In pain, it's important to have a night pain. In combination of these with the symptoms of the patient, radiograph, and the general progression, we can identify whether the lesion is benign or malignant. Now we come towards Ewings sarcoma. It's the third most common primary bone sarcoma. It's a small round cell lesion, usually in diaphysis or metaphyseal location, with a big soft tissue mass. X-ray show sucked on bone appearance. Often there is a cardamom triangle, moth-eaten, no soft tissue mineralization. Histology reveals round cells with no matrix, with a pseudo-rosette formation. Genetic studies show translocation 11-22, mostly tested in exam. This is present in 90% of the population, of the patient who have tumor. Workup include bone scan, METs to the bone, chest CT, and bone marrow aspiration to look for diffuse marrow involvement. PET scan has recently become popular for these patients for detecting occult mets. Treatment is with chemosurgery and then more chemo. Really, radiotherapy, if margins are positive or if lesion is too large, is also a possibility. With multi-agent chemo and surgery, prognosis around 70% for 5 years. Patient may have fever and may only resolve with chemo. ESR and WC are elevated, and do not confuse this with infection. Ewing is quite a good mimicker of infection. Patient presenting with METs have less than 20% survival at 5 years. Poor prognosis factors for Ewing sarcoma. 1. Spinal and pelvic involvement. Large lesion, less than 90% necrosis on chemotherapy. Elevated LDH and P53 mutation in addition to T11-22 translocation. So there is a double mutation, P53 mutation along with 11-22 translocation. There is a high risk that it will be poor prognosis. Nowadays, many favor over radiation, favor surgery over radiation, and some data suggest better results. No randomized trials have done up till now. Radiotherapy patients have about 5% chance of developing secondary radiation-induced sarcoma. Surgical lesions generally remain the mainstay for local treatment. The tumor cells of Ewing sarcoma are positive to CD99, but not for leukocyte common antigen.